Hi, Dr. Garima here again. Somehow my camera is not working today, so I'm just recording this video. It's a very good video actually that I wish to record and share with you all. It's based on combination syndrome. Uh, and one of this question is going to come in your exam definitely. So this would be the sixth question of mock 21. And before discussing this question, I would like to share this video with you, which I found on YouTube, an amazing video about combination syndrome. Let's go through a bit of theory and let me pause it here and now and tell you some things about it more, which helps you understand this combination syndrome. Again, it's a prosto topic. Many of you find that as your weakness and have requested many times to me to share more on prosto. So this is a very, very good explanation of combination syndrome, which would help you to understand what it is, what questions can be asked on it, and how to deal with it if you face it yourself in the clinical
Common
scenario.
complication in a single complete denture, that is, when the maxilla is completely edentulous and the mandible is partially edentulous with only the anterior natural teeth remaining, the maxilla having a single complete denture followed by mandible with a distal extension RPD. Common complication which occurs is known as the combination syndrome or anterior hyperfunction syndrome. It was first described by Kelly in 1972. The characteristic
So here, the thing to note is that the combination syndrome is also called as anterior hyperfunction syndrome, and it was described by Kelly. So write this down and memorize this.
features seen in combination syndrome will be discussed here, along with the sequel under which these events occur, the systemic factors which can aggravate this syndrome, along with what should we do to prevent this kind of combination syndrome occurring in a patient with maxillary complete denture and a mandibular distal extension RPD. So let us see what are the common characteristic features that occur in combination syndrome. The first one being loss of bone from the anterior portion of the maxillary ridge, followed by there is papillary hyperplasia in hard palate region mucosa. The third feature being overgrowth or enlarged tuberosities.
So here I would like to pause and share something with you. You see this papillary hyperplasia of hard palates mucosa. Now, what is hyperplasia? Hyperplasia is basically overgrowth of a normal tissue, and it becomes a very flabby one. Flabby one meaning that it can be displaced very easily. So when you receive a patient with a papillary hyperplasia, especially in this kind of scenarios, where the upper maxilla has been devoid of teeth and only the lower anterior teeth are present, and we'll come to the pathology and physiology of as to how it led to having a papillary hyperplasia, what kind of impression you will be taking to record the maxillary arch. Now see, we all know there are two types of impression. We have mucostatic and mucocompressive. What does mucocompressive means? Mucocompressive means you are putting something like an impression compound and you're pressing it like hard over the tissues, thereby putting pressure on the tissues to record it. Now, what happens in case when there is a flabby tissue? If you're going to put pressure on it, it will displace from its original position, and the impression that you will be recording would be a impression where the tissue has been displaced. That is not the natural position of the tissue. So if you manufacture your denture over that displaced impression, then definitely it's not going to sit. So you have to record these flabby tissues which are so easily mobile in such a way that their position is recorded very accurately, and that can be done only when you do not apply any pressure while recording the impression, which is called as a mucostatic impression. You understand? So you need to understand this difference. That's why whenever you have a combination syndrome patient or any patient with any kind of flabby ridge, you will always take a mucostatic. Static means you're not putting any pressure and displacing the tissue while recording the impression. Okay, let's proceed.
The fourth feature being the extrusion or supraeruption of the lower anterior teeth, the only natural teeth remaining. And the fifth feature will be bone loss and reduction of ridge height beneath the mandibular distal extension removable dental prosthesis. So, what is the sequel under which these events take place? First, there is bone loss under the distal extension RPD due to the irregular distribution of force between the anterior region of mandible and posterior region of mandible, which is followed by decreased occlusal load posteriorly as seen before and increased occlusal load anteriorly, which results in resorption of the bone in anterior maxilla due to the excess force transmitted. Due to these features, there is a change in occlusal plane and a loss of stability. The change in occlusal plane also causes a negative pressure on the posterior palatal seal, causing overgrowth of maxillary tuberosity and also papillary hyperplasia in the palate region. The resorption in the anterior maxilla also causes the labial flange of the anterior maxillary denture to irritate the labial mucosa, producing epilis fissuratum. And regarding the lower anteriors, it supraerupts and poor oral hygiene adding to it can lead to periodontal complications. From these features, from these sequel, Saunders in 1978 added 6 more additional features to the combination syndrome, including loss of vertical dimension, occlusal plane discrepancy, anterior spatial repositioning of the mandible as an habit, loss of stability and which leads to refabrication of the existing dentures, epilis fissuratum as seen before, and periodontal problems of the remaining teeth. So before starting for treatment of this combination syndrome, you should also know about the factors which can increase the occurrence of combination syndrome, like systemic factors including diabetes, osteoporosis, or dental factors like in case of class 3 jaw relation, patient has a tendency of biting more in the anterior region due to protruding mandible, or in the presence of parafunctional habits, or when in case the patient has retained lower anteriors for a long time, the habit of biting in the front teeth is more, and therefore these factors should also be considered before treatment planning for combination syndrome. Now when we take a closer look at it, we could see all these problems starts from the basic bone loss in the mandibular distal extension region. So our aim should be prevention of rapid resorption of the bone under this region and also prevention of excessive load in the anterior region, and our treatment should be directed towards this aspect. So our prevention should be retaining of the weaker teeth by endodontic and periodontal management. Extraction should be the last choice given. If extracted, try to fabricate a fixed prosthesis either using endoosseous implants or using tooth retained overdentures in the mandibular posterior regions. And also schedule regular recall and visits. If it is no other go and you are going for an removal prosthesis, check with frequent relining to compensate for the resorption, especially in the low syndrome. The first one.
So, having understood this, let's go back to this question. Now, I hope it is very clear what is combination syndrome. So, the main things that you have to remember is that in combination syndrome, there is presence of lower anterior teeth. There is no teeth in posterior region. Sorry, I sneezed. um, yeah, so there are no teeth in the mandibular posterior region, and most probably the patient is having an RPD. Upper maxilla is absolutely devoid of any teeth for a long, long time, leading to hyperplasia, resorption, flabby ridge. For the mandible, the patient learns to position it more in a class 3 fashion, leading to anterior repositioning of mandible. Remember this term, anterior repositioning of mandible. All right. Now, having understood this and the other things in the as short duration as possible, you can, of course, read more about the combination syndrome, but a basic idea you have it now. Now, whenever you'll have such a big scenario in the exam, your 1.5 to 2 minutes will just go in reading the scenario and understanding the keywords only. So you barely have time left to solve the SBQs. But whenever such big scenarios are presented, usually the SBQs are pretty much straightforward and they are one-shot answers that you just read and you should know. You don't even have to read the question again. But you have to read the scenario properly to understand what it is. So let's just start reading this question. A 76-year-old woman with Sjogren's syndrome for the previous 20 years in mild controlled form presented complaining of a poor fit of an upper denture and difficulty chewing and speaking clearly. She had been using water to compensate for dryness of her mouth and was taking prednisone 10 milligram every day for the last 2 years. So she's taking corticosteroids, okay? Because she has an autoimmune disease. Makes sense. Otherwise, patient's medical history was not contributed. The patient lost some of her upper teeth about 50 years ago, and she's 76 years now. So there was a long, long gap when she lost her upper front teeth and had a bridge, but eventually lost her remaining upper front teeth, requiring a partial denture. Now, she had two sets of denture for her upper jaw for the past 15 years, with the second one constructed less than a year ago. On presentation, the patient was wearing a removable maxillary partial denture retained by the bridge number 242526 on the left side and tooth number 17 on the right. Due to recent mobility of her upper right second molar 17, her new partial denture became loose and difficult to wear. Now, your examination revealed severe resorption of the buccal aspect of the upper jaw with over erupted lower anterior teeth. Basically, all the history geography is given. The crux is she doesn't have upper anterior teeth for a long, long time. There is a bulbous upper ridge. There is resorption of it, which is mentioned in the question, and she has over erupted lower anterior teeth, which is nothing but a combination syndrome. So now, on the basis of the clinical and radiological evaluation, when I've read this question itself, I know it's a combination syndrome. So I don't have to break my head. I pretty much have to just go and find that option in my options. The diagnosis is now here out of this three, we just discussed that combination syndrome is also known as anterior hyperfunction syndrome or Kelly syndrome, but Kelly is not mentioned here and anterior hyperfunction is mentioned. So I'm going to go with option B. Now, this syndrome leads to, now I just gave you a very nice term, repositioning of the mandible anteriorly. That is option A. Repositioning of mandible posteriorly cannot happen. Repositioning of maxilla anteriorly, no. In fact, maxilla gets more resorbed anteriorly. So the answer is repositioning of the mandibular anteriorly. That is the correct answer because it becomes more and more of a class 3 pattern. Best impression for upper anterior maxilla is. Again, we also discussed the science behind it. We cannot use a compressive impression because it's going to displace the flabby tissues, giving you a wrong record of the tissues. Hence, we will go with mucostatic impression. In a maxillary denture against natural lower dentition, best teeth of choice for the denture are. Oh, this is a nice question. See, you should never put porcelain teeth against a natural set of teeth because they are going to break and they will fracture because porcelain is nothing but glass, pure glass. And if you're going to give it a hit against a natural teeth, then it's going to fracture. So the best one is acrylic resin teeth. That should be your answer of choice. That is A, resin teeth. Reinforced resin is not wrong, but if I have a pure acrylic resin, I'm going to go with that. Where are the clinical radiographs preferably stored? Okay. Now, this has got nothing to do with the question given. On the camera, no, you should not. You should have a system which is accessible to all the clinic, basically a data-based system, a clinical software is what I mean. So it should be a software system which can be accessed to all the computers in the clinic in different rooms, not just on that particular desktop. So on the camera and on the desktop is not correct. Now in Synapse, I don't understand what Synapse is, but Diagra is a data systematic software system, and that should be your option of choice. So I hope this is pretty much clear and this clears more of your prostho thing and you are not feeling so underconfident. See, whenever you'll see a big scenario like this, don't get freaked out. The bigger the scenario, possibly it's a very straightforward MCQ kind of a question thing only. It's the smaller things which have the propensity to distract you and put you in a dilemma. But the bigger scenarios are usually, if you catch the crux of it, it's pretty much straightforward. But yeah, The bigger scenarios take your time, which is the worst part, because you'll be like very careful in trying to retain the information which is provided to you, and your 2 minutes straight away goes in reading that, and then subsequently to solve that entire SBQ you're left with a short amount of time. So if your concept is clear, a bigger scenario is actually a very helpful thing to you. So I hope this is clear. Let me know how you felt after this presentation. Feeling more confident, I hope, about the prosto thing. Off late, I'm shooting a lot of prosto videos, and I hope that is strengthening your prosto part. So leave a comment, how much I like to read them and respond to them. So I'm sorry I could not be visible today because my camera is not working. And again, for all the new candidates or the people who are watching my videos who are not my enrolled candidates, I've already shared the study plan. I've already shared all the books. All you need is the mocks like this, which I'm solving to practice, and you're pretty much good to give your exam. It's not a complicated exam, just your basic sciences and concepts have to be very clear. You don't have to break your head with 10 different vendors. These three things should be pretty much should make you prepared to give your exam. So yeah, best of luck and looking forward to your comments. Bye bye.